Good morning, everyone. I'm the community coordinator at Smart Patients, which is online. All you need to know really is smartpatients.com, and that will get you to the website. How many Smart Patients do we have here today? Just a couple. Several. Good. Okay. So it's nice to meet you all in person. And let's get started. We're going to really buzz through this because kidney cancer is a huge topic. And right here with the mouse. Okay. Kidney cancer is huge. And we only have half an hour, and we want some time for questions. So we're going to move fast to cover three major areas. We're not going to talk about clinical trials, but Smart Patients does a lot of work in helping people find clinical trials, evaluate clinical trials, get into clinical trials. So if you want information on that, come to us. Also, as Veronica said, don't use Google. Google will scare you to death. All statistics are out of date by the time they're published, by the time they're developed. So you're looking at things that happened 10 years ago to a group of people. You're not looking at what applies to you. So, and also you don't know how to interpret statistics usually. Most people don't understand what the median is or what they mean by all these terms, confidence interval, all this sort of thing. So Smart Patients will help you get the right information that really applies to you. Kidney cancer is huge, so we're going to talk about the special vocabulary that will help you to communicate more easily with your healthcare team and to be an informed partner in your decision making. The next thing is it's vitally important to consult with a specialist in kidney cancer, even if it's inconvenient and even if you only get there once in a while. And next, how you can safely learn about these things by talking with fellow patients and caregivers online at the right places, like Smart Patients. Along the way, we'll debunk a couple of misconceptions. So let's get started. Kidney cancer is a great big bucket of diseases, and it holds many separate diseases. What's in the bucket? All these different cancers. I didn't even put oncocytoma in there because that's usually benign, and we don't consider benign tumors cancerous. But there's all these different kinds of kidney cancer. I think everybody here is renal cell, but someday you're going to meet somebody and they're going to say, oh, I have kidney cancer too. And you're going to talk to them and they don't sound at all like you. That's because they have some other type of kidney cancer. But when we talk about kidney cancer, we usually mean renal cell carcinoma. Renal cell carcinoma is tricky, quirky, sneaky. Each case behaves so differently that some researchers now think each case may be its own unique type of cancer. That's one reason why RCC does not behave predictably. And that leads us to our first big point. Never say never, never say always. I've heard a lot of blanket statements about kidney cancer. They all turn out to be false. So don't believe a never or always statement. It can't be true. One oncologist told a patient that if RCC metastasizes or spreads, it always goes to the lungs first. Well, that's false. RCC might show up in your toe, your sinus, your breast, your eyeball, your intestine, your pancreas, your calf, your scalp. There's no rhyme or reason to it. There's no logic. There's no system. It goes wherever it wants. What we can say is that there are favorite sites for metastasis, and the favorite sites are lungs, bone, brain, and liver. But that doesn't mean that metastases will show up there first, or always, or ever. Predictions just don't work. We've had people who were told that they were going to have metastasis soon and to expect it, and they're waiting years later, they're free of metastasis. And other people were told, oh, you're early stage, we got it all, you'll never have another problem. And they develop a metastasis and decline rapidly. There's no way to predict it. But this unpredictability could be good news for you. Don't ever assume you're a goner. But it might be bad news. Don't ever assume you're out of the woods. You just don't know which way it's going to go. You have to be vigilant forever. You have to keep up with your scans. But this doesn't mean fear. It means diligent follow-up with CT scans of the chest, abdomen, and pelvis. Probably forever. And not worry, but alertness to the signs that your body is sending you. For example, if you develop bone pain or joint pain, or something like a pulled muscle that refuses to go away or get better, suspect bone metastasis. Get an MRI or a bone scan, get checked out. If you develop any neurological symptom, huge list, you don't ignore it. You go and get checked out. You start with a simple physical exam in your doctor's office or your oncologist's office. You may have done this. Watch my finger, don't move your head. Touch your nose without looking at it. Stand with your eyes closed, see if you can balance. Squeeze my hands. All these little tests. And the doctor will say, you seem to be fine. Or the doctor will say, let's send you for a CT scan just to make sure nothing's going on. CT scan, MRI, electroencephalogram, any of those tests. Fortunately, people who have brain mets, who have RCC, can do much better than the average patient. People with other cancers who have brain mets and people who have primary brain tumors do a lot worse than people who have RCC with brain mets. The blood-brain barrier blocks most drugs from treating brain tumors. So if you get a drug, you want it to be one of these drugs, one of these exceptional drugs that does cross the blood-brain barrier. But generally speaking, the preferred treatment for brain mets is surgery or radiosurgery. Radiosurgery is a separate procedure that we'll talk about in a minute, but whole brain radiation should be avoided whenever possible. Healthy brain cells are much more sensitive to radiation damage than kidney cancer cells. Whole brain radiation often decreases cognitive abilities for people who live more than a few months. And kidney cancer patients with brain mets can live a lot longer than that. So you don't want to damage your brain. There is a new technique called hippocampus sparing radiation that protects cognitive ability, memory, and personality, which is all very important aspects of life. This is done by shielding the hippocampus while radiating the rest of the brain. So it's basically targeted whole brain radiation. Insurance might not cover it, but if it doesn't, it's well worth whatever additional costs they want to charge you. It makes a big difference. Now back to that big bucket of kidney cancer. What kind of RCC is in the big bucket? Lots. Lots of different types. Most people have clear cell. There's collecting duct carcinoma. There's a lot of debate about is that really RCC or not, because it's rare, it's aggressive, it doesn't respond to the same drugs. But some people think it's RCC. Some researchers think it's not. There's two kinds of papillary. There's chromophobe, renal medullary, which is associated with sickle cell and sickle cell trait, translocational, unclassified, and the many genetic syndromes. If you were diagnosed before age 46, or if you had a tumor that was obviously growing for several years and you were diagnosed around age 46, you should have a full genetic workup according to the National Cancer Institute. And that's because there are many, many, many genetic syndromes. They require a different surveillance schedule. They might require a different treatment. They have different surgical guidelines, and most genetic syndromes also have other health-associated problems that go along with them. Like if you have Birt-Hogg-Dubé syndrome, you might have spontaneous lung collapse, and that might be the first sign that you have kidney cancer. So nobody's going to know that before they get diagnosed with kidney cancer, but afterwards, if you get diagnosed with Birt-Hogg-Dubé, you want to be on the alert for these other things that can go along with it. So, does everyone know what type of RCC that they have? If you don't, please find out. When my husband was diagnosed, we didn't know that you could have cancer in the kidney. And I don't think I found out the name renal cell carcinoma until probably 7 years later. Fortunately, he did very well, but there wasn't anything online 30 years ago. And it just wasn't there.
How do you go about being tested? I mean, you have to have a primary doctor refer you to that, or?
For the genetic testing?
Yeah.
Yeah, basically your oncologist can refer you. But yeah, your primary doctor could too if you were diagnosed early. But yeah, do get a workup, because if you happen to have a genetic syndrome, you want your kids to be tested, of course, and make sure that other people in your family don't have it. Most of you have already had surgery, and here are the different types of surgery to remove your primary tumor, either just the tumor or the kidney. There's robotic assisted surgery that allows the surgeon to sit at a 3D magnified viewer and use very tiny instruments to do very delicate work inside you. Laparoscopy is also called keyhole surgery, and there's a pretty good picture of it. Laparoscopy, one thing the doctors don't tell you is they fill you up with carbon dioxide gas, and then they leave it in there. And when they leave you to get well, that gas has to come out. And so they make you walk around, and it goes into your intestines, and the gas comes out in the usual manner. But people aren't expecting that when they wake up with a sore stomach and a bellyache.
Very painful.
That's,
It's very painful.
Yeah, it's very painful, and that's the difference between talking to patients and talking to doctors. Patients will tell you about the gas. So, here's hand-assisted laparoscopic nephrectomy. And in hand-assisted, they make one incision that's a little bit larger and put in a hand port, and the surgeon then pulls the kidney out all in one piece. It's important that the kidney should probably be bagged so that no cancer cells are scraped off as it's pulled through this port. RCC that has metastasized, partial nephrectomy. Partial nephrectomy, we talked about it, but here's a picture of, very basic picture of what happens. The kidney's been cut into, so it's going to take a little longer time to recover from, but the benefit lies in preserving as much healthy kidney tissue for anybody who's at risk of kidney disease or who has a genetic type of RCC, because genetic types tend to recur in the kidney. And lots of people have a whole kidney removed and then find out, oh, I have some genetic syndrome and my other kidney is at risk for multiple tumors. So here are some localized surgical options and minimally invasive procedures that are done instead of surgery. The minimally invasive procedures, radiosurgery, uses many tiny beams of radiation that come in from all different angles to meet inside the tumor. And it delivers a killing dose of radiation to the tumor while sparing the healthy surrounding tissue. This is very important for kidney cancer because most cancers, like lung cancer, you get broad radiation to your whole chest and it kills little tumors. You can't do that with kidney cancer because kidney cancer is very resistant to radiation treatment. But this way, you give it a massive dose of radiation while the rest of the tissue is spared. When it's done to the brain, it's called stereotactic radiosurgery. When it's done to the body, it's called SBRT, stereotactic body radiotherapy, or SABR, S-A-B-R, stereotactic ablative radiotherapy. And in patient slang, we call these procedures zapping the tumor. For radiofrequency ablation, scans are used to map and insert a needle-like probe inside a cannula, which is a slightly larger protective sleeve. It looks a little like a big hypodermic needle. And then when the probe is in place, they push on a plunger and the little probes come out. There's like about 10 little fingers that kind of open up like an umbrella and cradle the tumor from the outside. You can kind of see the little probes cradling the tumor in this picture. And then the probes are electrically charged. They create heat that kills the cancer cells. The probe is pulled back into the cannula, removed, reinserted again into the tumor in a slightly different position, and the tumor is cooked again. That's another piece of patient slang. Cryoablation is similar in technique, but the probe is supercooled instead. And the interventional radiologist uses a real-time scan to watch the ice ball form, and that's what's in the picture there, little ice ball. So, in a few exceptional situations, they will use localized treatment on a single tumor, even if they can't get rid of all the visible cancer. Generally, localized treatment is just for getting rid of everything that is visible. But if you have brain metastases, they will always treat those first. If your mobility is threatened, if you have significant symptoms like pain or breathing difficulty, they'll treat that tumor. Or if you have a single tumor that's in a life-threatening position, they'll treat that tumor locally. But beyond that, then we go to drugs. And drugs are the last resort. The reason that drugs are the last resort is just that they don't always work. And they have a lot of side effects. And when you start drugs, you might be on drugs for the rest of your life. So you want to put it off as long as you can. Drugs that work for other cancers usually don't work for RCC. However, drugs that work for RCC often do work on other cancers. And that's caused RCC to become a much more popular and exciting area in cancer research. At conferences, kidney cancer sessions now draw overflow crowds, and that's a huge difference. They used to be in little rooms like this with about 30 people, and nobody was very interested because there wasn't a lot to say. And that's because before 1992, there was no approved drug to treat kidney cancer. In 1992, the Federal Drug Administration approved interleukin-2, and it's not used very often nowadays, but interleukin-2 remains a very good treatment for people who qualify for it. It's the best chance of complete and lasting remission. For 13 years, interleukin-2 was the only drug that was approved. And then at the very end of 2005, Nexivar was approved. And in the very beginning of 2006, Sutent was approved. These two anti-angiogenesis drugs are TKIs, tyrosine kinase inhibitors, that block the growth of new blood vessels that feed tumors. We've come a long way since then. Now we have 12 drugs or combinations approved for treating kidney cancer. Special situations. If you have chromophobe, you might look at Lenvima plus Afinitor. If you have metastatic papillary, you might look at Avastin plus Tarceva. It's gotten very good results. If you have bone metastases and want a drug, you might try Cabometyx or interleukin-2, but usually we do localized treatment for bone mets because it usually is better results. With genetic syndromes, we treat them with nephron-sparing partial nephrectomies so that we save healthy tissue and kidney function. And if you have hereditary leiomyomatosis and renal cell cancer, you get surgery on your kidney tumors as soon as they reach 1 centimeter because they're very quick to metastasize. And with other genetic syndromes, NCI recommends removing all tumors from the kidney as soon as one of the tumors reaches 3 centimeters. And often this means multiple tumors are removed. So, how many of you knew all of that? Most doctors don't know this, most oncologists don't know this. Only very young oncologists got any of this in medical school. Oncologists with a special interest know all this and more, and you're very fortunate here at Sylvester to have doctors like Jaime and Mark who have specialized in this area and do a lot of study to stay on top of things. That's what Smart Patients does too. We stay on top of things. We learn a lot. We know that we need a specialist. We really, really need a specialist, even if you only consult with one sometimes. What you want, especially if you live far away, you want to find the best specialist that you can get to, and then find a local oncologist who's willing to work with your specialist, visit your specialist once or twice a year, confer distantly when you can, and have your local oncologist work under the direction of and in cooperation with the specialist. Because the specialist who is in charge of your case, if you put him in charge of the case, will be very deeply involved with you and know the wide range of treatments that are available. The local oncologist may be willing to learn that from your specialist. Some aren't. Find one who is. How do I know who's really a specialist? Look them up. This is a place where Google does come in handy. You can find write-ups on any doctor, and it will tell you specifically. Now, some doctors, people say, oh yeah, my doctor is a kidney cancer specialist, and I look him up and it says he works on lung cancer and breast cancer and melanoma and kidney cancer and bladder cancer and prostate cancer and multiple myeloma and 16 other cancers. That guy is not a specialist. You want a specialist. So your actual treatment is carried out closer to home, and you are under the care of a specialist. Now what? You want to go online and talk to other people about what's going on. You want to find out who they're seeing and what they're doing and what's available that you're not getting. So, speaking of specialization, Facebook is not the place to go for medical information. It's called social media for a reason. Facebook doesn't protect what you post. Medical information you share there is being sold or stolen from closed and private and secret groups. And despite Facebook's claims that they aren't doing it anymore and they'll never do it again, and they never did it in the first place, this is a report from February 2019. It's still going on. The problem is serious and real and ongoing. Also, the past comments on Facebook are very hard to find. You're supposed to use your real name, although not everybody does. Most of the people on Facebook don't really care about science or research. If you're looking for friends, you're looking for emotional support, great. But if you want medical support, come to Smart Patients. Biggest online community for kidney cancer in the world. And we help every patient build their knowledge, build their confidence, and know that together we can face anything that comes along. We talk about everything, literally. And one of the things is like the special information on autoimmunity. If you have an immunotherapy drug, you need to know to be aware of possible autoimmune side effects. This is vitally important because every day that you delay in getting the right treatment for autoimmune side effects might mean a week in the hospital. Smart Patients is set up specifically for patients. We promise your data and contact information will never be sold. You can search for anything that's on Smart Patients. We scrupulously guard your privacy, your anonymity, anything you share with us. We don't ever try to sell you anything. You won't see any ads. You won't get any spam. We don't promote any clinical trials or drugs. We respond personally to your questions, suggestions, and ideas. And most importantly, our thousands of members say, it's a family. Together we save lives. It's wonderful. I couldn't be prouder of what we do, and I hope you will join us. Thank you.